Hello, everyone, and welcome to this evening's ASME Bite-Size session. My name is Sarah Edwards, and I'm the Honorary Secretary for ASME. And in my day job, I'm an emergency medicine registrar or senior resident. And tonight, we're talking about tips for teaching evidence-based medicine in the clinical setting. And I've got two fantastic presenters who are joining us internationally. We've got Sonam and we've got Basil, and I'll let them get started in a moment. Just some housekeeping. So this session will last about 45 minutes. If you wish to ask any questions, ideally use the chat field, but our presenters are happy to take questions. If you put your hand up, using the hand up sign. And if you've got any issues or technical problems, just pop it into the chat and we'll try and get those sorted for you as quick as possible. So I'm going to hand over to our presenters and thank you very much.
Thank you, Sarah, for your introduction. I'm Sonam. I'm a clinical rheumatologist, and I work at the Legacy Salmon Creek in Vancouver, which is a city in Washington State. I'm an associate program director for the residency program. I'm also the clinical assistant professor at the Washington State University Medical College. And I will hand over it to Basil.
Hi, thank you for having us here. My name is Basil. I am an academic hospitalist in Rochester, New York. Rochester is kind of in the upper part of New York. It is closer to Canada. I'm an associate program director for my residency program and a clinical assistant professor at the Lake Erie College of Medicine. An interesting tidbit, Sonam and I did our residency together. We were chiefs together, and now we are continuing to collaborate on our love for EBM together. So as we go through the talk today, it's a very low-key talk. I just wanted to say that we'll be using a little bit of an interactive component in our talk. So we'll be using something called a Slido. So you can either go to slido.com and put in the email, the meeting ID, or scan the QR code through your phone, and it'll take you right into the meeting. You don't have to scan it again and again for every question that pops up. Once you're in the website, it'll auto-populate as we go through the questions. So just to get a little baseline, I know we have a few participants here, but to know our audience, if you could just indicate what is your current role? If you're a medical student, a foundation trainee, a senior house officer, a registrar, or consultant, or another. So I think we have split a 50-50. So this talk is exactly this. And just to get a little bit more background, how often do you teach evidence-based medicine in your current clinical setting? Excellent. I think this talk is well suited for you so that you can go to the next level where you can incorporate it more in your clinical practice.
Great. So this brings us to our agenda for today. And what we plan to discuss is what is evidence-based medicine? What are the steps of evidence-based medicine? Why is it important to teach evidence-based medicine? And I think the most interesting part is how to teach evidence-based medicine in a busy clinical setting. And that's the fourth quadrant is where we are going to spend our most time. So let's start with what is evidence-based medicine. And really, I think we are preaching to the choir over here, Basil, but EBM is a conscientious, explicit, and judicious use of current best evidence in everyday practice. It integrates best research evidence with clinical expertise and patient values. I think you really can't divorce research evidence from patient values. It's all three of them really form the three strong pillars of the whole EBM. Next slide. And these are the 5 steps of EBM practice model. It really starts at the bedside and ends at the bedside, right? So you assess what is your knowledge gap or what is your trainee's knowledge gap. You formulate the right question, you acquire the literature, you appraise it, and then go back and apply it to your patient. So these are the 5 essential steps in practicing EBM. And really, as I stress upon it time and again, that it is not to be viewed in isolation. It has to be viewed in the clinical setting, in that moment. And that's why we feel this topic is just so important. The application part is just so important. Next slide. This brings us to the next question. Why is it important to teach EBM to our trainees, right? So clinicians have about 5 to 8 questions per shift. There is an increase in volume and speed of new data being published every time. And this makes it challenging to find the right evidence at the right time, given our time constraints. So that is why it is essential to navigate through these EBM resources swiftly, assess their trustworthiness, and maximize chances of quickly finding the answers. And this is where we really want to train our trainees, right? How to go through this vast amount of knowledge of EBM and how to skim through it and try to get at the best evidence in the least amount of time possible. So that's where we can help them the most. Next slide. So this is the current approach in clinical teaching, right? This is what usually happens at the bedside, be it in the clinic or in the inpatient world. We come across a clinical problem, and then either the consultant or the attending physician, as we call it in the United States, has their own experience and expertise, and this is used to make a decision to solve the clinical problem. And this is a perfectly fine situation. However, we don't incorporate the EBM teaching into it. And in our next subsequent slides, we are going to try to emphasize on changing this model a little bit so that we can incorporate EBM teaching into our everyday practice. Next slide. Okay. So after giving you the basic background, I would like everybody to perhaps switch on their microphones and even their video, because we are just a small group and I would love to see the faces of our participants, and the next few minutes are supposed to be interactive. So the prompt is really, we would love to share, listen, and explore successful methods of learning or teaching EBM in your clinical setting. What has worked for you? We would love to hear that. So if you could unmute your microphones and take a stab at it. We're just a small group.
Hi, I'm Dr. Pranesh from the Clinical Teaching Fellows at Moorfields Eye Hospital in London. So I involved in a lot of teaching for the students, the undergraduates as well as the postgraduate trainees. And it's a big challenge to teach medicine in the clinic, because of the time constraints. I think that's going to be a big challenge. But what has worked for me despite the time constraints is that we have a very protected learning or a teaching time dedicated for that. So we make sure that we see patients, selective patients, patients who can be of help for the students. So patients, for example, if I'm an eye doctor, so if there is, the students want to learn patients who are to be seen in the A&E in their future practice. So I pick patients who have acute red eyes, and I give them materials beforehand, before the session, before the clinical teaching session. So that what happens is the students have an idea about the basic fundamental concepts. So in the actual clinical practice, while teaching in the busy clinic, it makes much easier for me to kind of connect with them because they already know something about the condition before. So that really helps us to get a good perspective about the patient and the situation as a whole. I think that really works. That really helps to teach or to at least introduce the materials to the students beforehand.
That's a great point, and thank you for your input. I think the only one comment I have on this is what we are talking about is the background and the foreground questions. I think that's we are getting at. So looks like you're giving them a good background of what they might see in the clinic or they will see in the clinic, and then you can further build their knowledge through the EBM lens when you actually get to the clinic. I think this is a fantastic way to bridge their knowledge. So thank you for contributing. And we have another hand raised, Edmund Jack.
Yeah, hi, hope you can hear me okay. I'm a GP and I teach about evidence-based medicine in the southwest of England. I lead the medical school teaching at the Peninsula University in Plymouth. I think it's a really interesting question as to what are we doing when we're doing evidence-based medicine in the clinic? Because you presented the definition that I think we're hopefully all pretty familiar with and which makes a lot of sense. But when you translate that into the actual day-to-day practice, it's pretty rare to sort of follow through all 5 steps of evidence-based practice. And I suppose that's something I've, in all honesty, wrestled with a little bit and why I was interested in joining the webinar today. And I think I probably just teach it in little bite-sized chunks. So just getting my registrars to recognize when they don't know something and formulate a question, that might be a little opportunity. Or obviously in general practice, we do a lot of shared decision making. And I think that's also a prime opportunity to try and incorporate some principles about evidence-based practice and how we explain those sort of effect sizes and things to our patients. So I'm interested to hear other people's perspectives on how they do that and what they actually define evidence-based practice in a clinical setting as.
Thank you so much for your answer and thank you so much for contributing. I think we are definitely going to talk about how we do the shared decision making and incorporate it with evidence-based and incorporate it in our teaching. And we are also going to talk about the PICO questions and how to incorporate that in your clinical teaching in a short amount of time. I think those are great thoughts. And if you're doing it regularly, I think kudos to you for doing those at a regular cadence. Both great points. I think Pranesh, you had your hand raised.
Yeah, thank you. So to answer Edmund's dilemma of that kind of difficulty to apply all the 5 steps of the evidence-based medicine practice model, I think you might be talking maybe in a while now, but we kind of follow this 1-minute preceptor model, which has really worked really well for me given the time constraints within a short span of time, trying to bring all these 5 steps together in a beautifully blended way. I think that's something which I really find things have really worked when it comes to teaching in a busy clinic. The teaching, not just with the teaching, but also you're helping the students to assess their work as well. Yeah, thanks for that.
Excellent point, Pranesh, and thank you so much for your input. Anybody else?
I think Amandeep has a comment down there. He's sorry that he doesn't have camera audio function. He's a clinical teaching fellow in the UK, and he have worked in places where we have access to up-to-date or BMJ best practice resources, which have enabled us to look up interesting points of cases we see or signpost students or other trainees to for further reading. I think this is a great point, Amandeep. Thank you for joining us. And as you will see as we go through the talk, we, like how Sonam said, we're all preaching to the choir here. We all know how important EBM is in our field. And we are here to offer a few suggestions and resources and steps to help you get through those 5 steps as we continue this teaching.
Excellent, excellent. So we can move on now to our next question.
So here is another, just wanted to see, like we already mentioned a couple of challenges that we face when we're teaching EBM in the clinical setting. Was there anything else that you feel were common challenges you encounter while teaching EBM in the clinical setting? Time is always a big one. Yes, we recognize that.
Space constraints.
Medical emergencies.
Medical emergencies, yeah.
Not feeling it's for them, not appreciating the relevance. Absolutely. I think something we are seeing more and more often these days. Knowing what resources are reliable and accurate, patient discomfort, defining what we should be teaching. Audience of different grades. Incorporating what activities and tasks. Absolutely. When you're on a busy clinical schedule, sometimes becomes more challenging to do that. Getting people to actively listen in busy environments. All these are great points. And hopefully, as we go through our rest of the presentation, you'll start identifying a few strategies and a few tools that would be helpful that may help you address some of these challenges.
Great, thank you for your interaction. And this brings us to the toolkit for clinicians to help teach EBM in the busy clinical setting. Next slide. So let's build upon the basic skeleton of EBM, the steps of EBM. So as you're aware, the 5 steps of EBM. Assessing your knowledge gap, or you're assessing the learner's knowledge gap, right? So assessing the learner's knowledge gap is during that clinical encounter. It may be in the emergency room, it may be in the outpatient, inpatient, or even the ICU, correct? So I think assessing the knowledge gap is important. Next step is to ask the right question, right? Help the learner to formulate a PICO-TT question. And I think most of us already know about the PICO-TT question, but I'm going to quickly go over that in the next few slides. I think the ask component can be done pretty well in most of our clinical settings, right? Giving the resident or the learner the opportunity to formulate the PICO question is a task that takes less than 2 minutes and can be done at the bedside or maybe while rounding later on. Now comes the acquiring piece, right? So encouraging the learner to acquire evidence from appropriate resources. And we are going to talk about what do these appropriate resources mean. And we will talk about it mainly towards the end of this session. This we understand because of time constraints, as everybody pointed to, might be difficult to do on the same day or during the same interaction with your learner. But this is something that you can ask the learner to do it by themselves by giving them some resources. Next is appraising the literature. This may or may not be done at the bedside. Remember, this may or may not be done in the clinical setting. We will also share strategies on how it could be done in the clinical setting a little later. But this is mainly, I see this done in morning reports or journal clubs, where they really learn to appraise the quality of evidence. And next is application, right? Application, you can do it in 2 ways. One is provide feedback when the learner is explaining the evidence to the patient. You can do it that way, or you can actually role model, right? That's the best. I mean, granted, it's a little passive learning for the resident, but I think undergraduate student or a postgraduate, early postgraduate training, nothing better than role modeling a shared decision making, incorporating the evidence-based guidelines, right? That actually brings out that underscores the importance of EBM in day-to-day practice. And then this is how trainees will understand that this is not an isolated skill. It has to be incorporated in the clinical setting. You need to incorporate this in the clinical setting. And the first step is role modeling. So that's how we visualize EBM skills to be taught in the clinical setting. So this was just our brief skeleton. And now we are going to build on this even further by giving you 5 tips from our toolkit. So let's go to the first slide. So the first slide this is the first tip, where we talk about the 6 T's. And this is something that I learned when I attended the evidence-based teaching practice at the Duke University for the last couple of years. So this is a helpful chart when you are thinking that you need to teach a small nugget, a bite-sized concept, or to cover any sort of EBM teaching in the clinical setting, right? So you need to be vigilant about these 6 T's. The first is time management, right? Make sure that it is brief, it is to the point, it is clinically applicable, right? Teamwork, ensure engagement. And I think engagement will only come when it is relevant to the patient sitting in front of you, right? That's the only way to engage an adult learner. Next, tools. If you are aware of any online tools, any online calculators, if you're aware of any infographics or any particular EBM related calculators, you can actually demonstrate the use for your trainees, right? So use your tools well. Don't over bombard, because remember, you have a limited time. So try to use your tools well. And triage. I think this is a very important thing, especially for early teachers, is you are bubbling with knowledge. You want to give it all, but really try to take a step back and decide, what is the most important thing? What is the one thing that I want my resident or trainee to know at the end of the session, right? So please triage. Don't try to cover the whole thing. That's almost impossible. And of course, the tone needs to be a safe environment. We don't want to make it a hazardous environment where nobody wants to contribute. And make sure you have one take-home message, right? Make sure that you drill down that take-home message. And then there are certain other things that you want to make sure that space could be an issue, right? Somebody brought it up. Make sure that you have a nice place to sit down and talk about it, or if it is going to be in the elevators, shuffling between wards, make sure that you are not disclosing any HIPAA related things that come up. So make sure you are keeping in mind what space you are in while discussing all these tidbits. So these are the 6 T's that you have to be aware of. Let's talk about the next tool. That's the PICO-TT tool. So over here, you can really do the assess part of it and ask part of it, right? And that's why I find this tool to be super helpful. And here's a question, right? So here is just an example. You're seeing a 62-year-old male with cancer who presents with recurrent DVT, and you're seeing this patient with a medical student. The student is familiar about data for DOACs in patients without cancer, but they are less conversant when it comes to patients with cancers. So I think this is a good learning opportunity, and this is how you assess your learner. And then you prompt them to do this PICO-TT question, which comprises of the patient, the intervention, the comparison, outcome, type of question, and type of study. Next slide. And really, for the sake of time, I have already put in these answers. And this is how you build up on your PICO-TT tool and really scribble on a piece of paper and hand it to them, right? When they can really acquire a praise and then bring it back to the clinic setting. Next slide. Most of you might have heard about this educational prescription. it is really building upon the PICO-TT tool, right? So you have your 4-part clinical question in the form of the PICO-TT tool. It should be co-created by the faculty and the learner. But there are some more important administrative or time-based things that are incorporated into this educational prescription, right? You will be sharing with your learner what strategy or where they will be presenting this, the thing that they have really looked up, date and place. Where are they going to present? When are they going to present? So I think this brings back to setting expectations, which is also an important job of a teacher. And then the learner presenting this educational prescription has a few pointers to cover and make sure that they are completing the task at hand. So again, this is going over the assess and the ask part. So remember the PICO-TT tool and the educational prescription. Feel free to ask questions in between. Raise your hands, not a problem. The next resource is Teach Cards. This is compiled by University of Wisconsin in the United States, and it goes over 4 of these 5 steps. You have the QR code. You can go to their website and get the Teach Cards for yourself. And it is supposed to be done maybe during an inpatient rounding. When you've already finished bedside rounding, you come in to discuss the plans for the day, and then you're sitting at a table, you have access to a computer, or you might have access to these physical Teach Cards that you can actually download from their website. Next slide. Next slide. And what you see over here is just an example of these many teaching cards. So if you have a case of meningitis, you pull up a meningitis card and you go through the background questions with your lower level trainees, and with your higher level trainees, you want to ask some foreground questions. A question would be, in adult patients with meningitis, do steroids improve morbidity and mortality? You can make a PICO question out of this, use the educational prescription, and then they come back with the answer. So you see how these strategies could be beautifully integrated. It all depends upon your time, how much you have, and how much you want to utilize for that particular instance. So a great resource. And this brings me to the shared decision-making. In the United States, Mayo Clinic has developed these fascinating tools. Again, a QR code is available that you can really use when you want to apply evidence-based to your patients in the moment. And this is an excellent tool if you want to role model evidence-based medicine. Next slide. And I'm showing you a screenshot from the osteoporosis risk tool. So if you see, it really gives you the absolute risk reduction. After using the bisphosphonate, you can see the risk of a fracture is reduced from 19 to 11. And it really shows, the graphics are powerful. You can calculate the patient's risk. You can go over the cost, the side effects. And I think this is a beautiful way to incorporate the absolute risk reduction and number needed to treat at the bedside. So do explore these. Tools. Next slide. This is another way that you can teach the appraise part of it, remember, in your clinical setting. And this is, again, a method that I adopted from the Duke EBM workshop. So this is called as grab bag. So it's literally a grab bag. So you can have these small mini topics that you can hand over to your learners, right? And they can just teach. This is peer teaching, right? They talk a little bit about number needed to treat under 2 or 3 minutes and teach their peers about it, right? So this can be done quickly when you are sitting down and rounding. It's easy to incorporate. It doesn't have to be done all at the same time. If you are going to be there attending for the next 2 weeks in the inpatient setting, you can just do one topic a day, right? So it can be as easy as that. Next slide. And the next few slides, this is again from the Duke University's page. It's easily accessible. If you type in Duke Evidence-Based Practice Home, this website comes up. It is free for everybody to access. And there are these great resources. So if you go to the next slide, there are some resources on how to generate a PICO question. Next slide is study design, where it talks about the pyramid that we all know and love. Next slide is on how to search. So there are some important tip sheets on PubMed and Embase tip sheets. Next is appraise. There are some appraising tools that you can hand over to your learners. I really like the calculating results, the number needed to treat, and these are some great quick videos that you can ask your trainees to take a look at before coming in the next day. And the last tab is excellent for all of us as teachers, right? I really love the tips introduction series published in the Canadian Medical Journal a long time ago, but they are still relevant. So do make use of that if you are hoping to discuss a specific bite-sized topic for your learners. So with that, I will hand it over to Basil.
Thank you, Sonam. So Sonam has already shared a few resources, and I'm going to continue to expand a little bit more on that, talking a little bit about certain resources and their advantages and disadvantages. It incorporates a little bit of the acquire and the apply portion of the EBM, as we will continue to see. So the first one I want to quickly talk about is about summary resources. I'm sure most of you are familiar with UpToDate and Dynamed. I'm not too sure what is used most in the UK system, but the main advantages of this are they're quite consolidated. It gives a great overview of the topic, but there are a few challenges with it. There's a risk of becoming over-reliant on these resources instead of having to verify the source data ourselves. There's definitely a loss of your critical appraisal skills as you get more and more engaged with these resources. And there is some lag time. I'm not sure about Dynamed, but for UpToDate, it's up to they review sections every 4 to 6 months. So there's definitely a lag time, especially if it's something that's quickly evolving, as we were all familiar with the COVID pandemic. Key journal subscriptions. These are also excellent resources. The New England Journal of Medicine, the BMJ, the Lancet, the NEJM also gives a quick summary of important articles that have been published over the past week. It's a subscription-based model. The advantage of these are they are curated, high-quality articles. You get early access to them. They are all with established credibility. But as you see, there's a lag time from the actual research time to publication. It's a narrow focus, doesn't incorporate a broad spectrum of issues, and there are definitely cost barriers associated. We are familiar with the various search databases. They include PubMed, EBSCO, and TRIP. TRIP is something that I use often in my practice, especially when I'm working with the low-level learners, only because TRIP allows you to put a question already into the PICO format while you're searching for it, so that eases the work for the graduates who are still learning EBM. It's a comprehensive search. You can refine your results, but the results, depending on the question that you're asking, can be quite overwhelming at times, especially if it's a new learner. Again, there is no critical appraisal of the article that is isolated. You need to go over it yourself and see how relevant it is for you. And you definitely need some degree of search skills, especially with PubMed and EBSCO, when you have to use certain operators and have a search strategy in place so you get the most relevant results for the question that you're asking. In clinical practice, we are quite familiar with medical calculators and risk tools. The commonly ones used are MDCalc, Calculate, and someone did speak about the Mayo Clinic shared decision-making tools. It automates complex equations. It's a consistent application. It allows you to risk stratify based on the patient that you're taking care of. There are disadvantages for this too. There's potential for over-reliance and then forgetting how you actually get to the number that they give. If you put an incorrect data point, you would get an incorrect result. And it may not apply to all populations. There are certain for example, the risk calculator scores, the certain age group during which you should be applying them and not for all patients. So I think that nuance needs to still be taught to our trainees. Clinical decision support tools is becoming more and more prevalent. So where a quick background is like it's medical knowledge, using patient data, use electronic health record or electronic medical record, and they give you very case-specific advice. It's integrated guidance at the point of care of the patient. It has got alerts and prompts that are built in that can catch errors. The main issues with it is this an alert fatigue, especially if this is integrated more, you get all these pop-ups when you're navigating through the patient's chart in the electronic health record, and that can become quite tiresome. And it requires ongoing customization. The algorithm will need to be updated based on what new evidence is coming out. So it's a good support tool for existing conditions. For new things, it's probably not where it's supposed to be yet. A common question we get asked is, where are the apps that you commonly use when you're trying to teach EPM? So there are few of them. There is something called Pathway, which has got all the guidelines for different medical conditions that's most up to date. There is an app called Journal Club. Journal Club also gives you a quick summary of various high quality articles that you can use to quickly refer. It has got some appraisal in the app, but again, we need to cross-check and make sure it's right. And then there's an app called Just-in-Time Teaching. I think it goes along well with the 1-minute preceptor model. So this gives you various tips and suggestions and identify areas where you can use the just-in-time teaching to teach our trainees. The advantages of this, it consolidates all the tools in one place. It's portable for point-of-care use. It's got a very engaging format. But disadvantages are the quality control is sometimes questionable for these. You're relying on someone else to do the work for you, and then you review and see if it's good. There are certain data privacy issues that are associated with some apps, and they usually lack some rigor to its development and application. I would like to talk a little bit about artificial intelligence in EBM. I think as you all can keep seeing, the artificial intelligence is starting to take over several facets of our life. ChatGPT, Claude, and starting to come in the evidence-based medicine realm with Scholarly, PaperPals, ResearcherLife. So there are a lot of tools that are available out here. There are a lot of advantages to it. It's fast. It quickly summarizes things for you. They can be very targeted. Some of the builds now are very interactive and personalized, which enhances your experience with it. But it's not without its challenges. I think the most highest concern issue is that there's a loss of nuance and context. These evidence-based medicine, as we all know, needs to be finally applied to the patient that we are taking care of. And sometimes that is not recognized by these AI tools. You can become over-reliant on them. AI itself, based on what algorithm it has and what learning model it was trained on, has got its own set of biases that will need to be accounted for. There are reliability issues with the evidence that comes out. I'm sure that you've seen a lot of those cases where the references themselves are all made up by AI. And it's a cultural shift. I think there's something that is going to become more prevalent, and learners and educators may resist the use of AI due to the fears of loss of human interaction and mentoring. So this cultural shift will take some time. I think there is an ideal scenario where it will be a human AI hybrid, where AI will be implemented to maximize benefits and minimize the risk. And a human AI model is likely to take advantage of strengths of both. I think we talked about how we can use EBM and what are the tools that we have. I think it's also important that we need to continue to build our skills at getting better at teaching. And there are a few ways that we can quickly go over. As you know, nothing beats practice. So deliberate practice is where you are focusing on the areas that you need to improve on, and the more you practice it, the sooner you get better at it. I think teaching journals are also another great resource where you make a note about what you taught, how you taught, and what is the kind of feedback you got from it. And then you would see over time the areas where you're getting better at, certain areas where you perhaps need a little bit more work, certain concepts that are not getting across that might need a different strategy. I think when we are working with trainees, learning about the adult learning principles, it goes a long way. I think there is a difference in the approach that is taken to when you're dealing with adult learning. And I think once we are more familiar with its concept, that makes our job much more easier. If there are certain courses that are available to you to do to teach EBM, I think that's something we should take. I think in the US, Sonam does it in Duke. I have been to the McMaster's course. So based on what is available to you and what resources that you have, certainly taking some courses will help this. And if you have a great teacher at your institute, someone who is very involved and closely involved, you can invite them to coach you, to see how you are doing when you're teaching, just to observe it, see how you're doing, and then afterwards you can debrief with them and get feedback on what areas you could have done better, which areas you're doing good. So I think that is also very important. So a few take-home points as we come towards the end of our talk. It's the recognition that stand-alone teaching improves knowledge, but does not improve skills, attitudes, or behavior. As you know, clinically integrating teaching improves knowledge, skills, attitudes, and behavior. It's important for us to continue to develop our skills as teachers as we teach the next generation of trainees. To identify our resources, we have shared a few here with you today. There are lots of them out there. I think you can go through them, identify those that work for you and your clinical situation and your practice, and those that do not, and then implement them and apply them in daily practice. I think one thing I have learned since I've been practicing is that it initially did take time, but as I kept doing it more and more, as I became more familiar, it became easier. So application in daily practice goes a long way. So I just wanted to see how our opinions changed compared to the start. So now that you attended this session, how often do you plan to teach EB in your clinical setting? Yeah, so glad to see this. This makes us happy. I'm sure Sonam also shares my feeling. It's important to get it through to our trainees. And just for us to learn as we are also doing this, it's important for us to get feedback. It's on a scale of 1 to 5, with 1 being not at all helpful and 5 being extremely helpful. How helpful did you feel the session was for you? Thank you. And thank you for spending your time with us. This is my and Sonam's details. My puppy was very much a part of this presentation, and he was through each and every slide. He was by my bed. So thank you all.
He approved the slides.
Yes, he did approve the slides. Thank you so much, and we're happy to take any questions if you have those.
Thank you so much, both of you. It's really interesting talk, and thank you to the audience as well for getting involved. As Basil has said, are there any final questions, comments, thoughts before we wrap up the session for this evening?
Edmund has his hands raised.
Hi guys. Yeah, just interested. I teach at I'd add to the list of excellent courses that you mentioned, the teaching evidence-based practice course at Oxford, which I teach on and can recommend. Interestingly, when I was there was a talk by Gordon Guyatt in which he suggested actually we shouldn't be teaching, or basically we shouldn't really be trying to teach critical appraisal as a skill to our tutors. We should just teach how to basically teach the sort of grade criteria for looking at guidelines, teach how to explain numbers to patients, and teach how to understand our patients' values. Sort of somewhat provocative, but I just thought I'd be interested to know what your thoughts were on his views there.
I was thank you for bringing up that point, Edmund. I was at the McMaster course which he does. I think the last one was last year, and he did bring up that point. I think we are a little bit away from it. I don't think we are ready for that yet. I think that is probably where things are going to head. I think it's going to happen, but I think as of now we are not at that stage yet. I think there's still value in teaching critical appraisal skills. I think that's how the learners learn. I mean, I think there was a comment earlier saying that there seems to be a waxing interest in evidence-based medicine overall. And I think that if we model this critical appraisal role, it will engage more learners to become interested in evidence-based medicine. And I think that is also important as we move forward, is that we need to have these learners still engaged in evidence-based medicine.
I agree with you, Basil. And I think the shift that I have seen since we were residents a long time ago, we were taught the critical appraisal skills for almost all types of articles or all types of studies. But what I'm noticing now is I'm more focused to helping my learners critically appraise guidelines or critically appraise systemic reviews, and maybe RCTs is where I am more gravitating towards, rather than doing all our diagnosis, prognosis, and so many other types of articles. So I think that's where I'm gravitating towards when I help learners critically appraise articles in journal clubs. But really in the clinical setting, in all honesty, I'm more towards role modeling, how to apply it to the patient using Mayo Clinic tools, or more towards formulating that PICO question and getting them committed to find that answer and then discussing it as a group the next day. I think those, to me, in my clinical practice as mostly an outpatient rheumatologist, that's what I see more practical and more easily incorporated. And then, of course, the bedside physical exam, which there is an excellent resource by JAMA where you can actually talk about likelihood ratios using either rheumatology labs or rheumatology specific physical exam maneuvers. So that's the other thing that I incorporate during my clinical teaching, EBM.
Thanks, both. Do you mind just sharing your contact details again? Thank you.
And I think Pranesh has his hand up.
Yeah, thanks, Dr. Sonam and Dr. Basil, for this excellent talk. It was really an eye-opener for me to realize that we need to teach evidence-based medicine in our clinical setting, because we try to teach medicine, but we don't really show the evidence behind what we are teaching, actually, maybe because of time or we take things for granted. But I think that really shows that we are serious educators and we are trying to follow scientifically based medicine than experience-based. But my question is regarding the PICO questionnaire. What I understand is that to actually apply PICO questionnaire, the students should have a basic understanding of statistics or the ability to read a paper and how to critically appraise the particular paper. So I think that's a bit of a challenge, because when I teach undergraduate students, I don't really expect them to be very good in research aspects of it. So how do you tackle that? How do you go about that? Thank you.
Basil, do you want me to take
Sure.
it?
I can take
Okay.
it. So, I work more in inpatient setting in the hospital, and the Sonam works more in the outpatient setting. I'll give that as a background. So I do have medical students that work with me. And when it comes to PICO, I think the PICO is structured in such a way that you don't have to, at the get-go, medical student doesn't need to go through the statistical tests that have been done and where the tests that they're doing, how is it relevant? I think PICO sets the stage for them to at least come back with that. Okay, this is what I found out, and this is the population. This is the kind of article that I looked at, and then I start building on that and saying like, okay, hey, maybe this is not the right article that you have chosen for this. Maybe this is a different article you can try out, or maybe you looked at the comparison group wrong. And once I assess and see how they are on the learning curve, that's when I can step up my game at that point. It's like, okay, if I see that they're doing a pretty good job at it, then my next step of teaching is, okay, let me get you into like, okay, this test that they used, what does it mean and how do you get it? So I think it becomes nuanced based on the trainee and the level of training that they have.
Yeah, thanks for that, Dr. Basil.
Yeah, and I think it can mirror even in the outpatient setting, depending upon the level of your learner. But then also really our focus is not to make them statisticians, right? Our focus is for them to be good clinicians. And to be a good clinician, you need to really understand the evidence and apply it to your patients. So if you think about it, you just need a clinician to understand few concepts that were listed in the grab bag, right? So if you focus on one of those and help them understand one important finding from that paper, I think your job is done there. And really, you don't have to go through the complicated statistical part, which might turn off your learner right there and then.
Thank you. Thank you so much.
Great. Thank you very much, both. It's been a fascinating hour, and I'm afraid we're going to have to draw it to a close. So thank you very much again. And I hope everyone listening, both now and in the future, enjoys this session. So thank you very much.
Thank you for having us.
Thank you.